So there's many aspects and things you need to look at when you're looking at the microenvironment, both from a B cell, from heme, and also from solid tumors. A number of cells play a very important role. But initially what happens is you have an event that causes, oops, you have an event where you see, I'm sorry, you get a effect where you have tumorigenesis and you have just intrinsic tumor cell survival. And eventually what happens is that you reach a point where you get chemokine and cytokine secretion, where you get this inflammatory response, and you get the recruitment of inflammatory cells, which is dependent on PI3K delta and also PI3K gamma, the isoforms of class 1, which are highly expressed in lymphocytes. So you see this recruitment and you build this microenvironment. This microenvironment then kind of shapes the tumor where it supports its expansion and its survival and also homing. And in solid tumors, you see the promotion of angiogenesis and vascular editing. So what are the cells that are important? I mean, you could divide this and then subdivide it forever and ever, but from a high level, from looking at the B cell microenvironment, some of the cells that are important are macrophages, TAM tumor-associated macrophages, the fibroblast, T cells, and different subsets of T cells, so the CD4, CD8, T helper cells, and then also the cancer cells themselves. So it's a very complex situation where you actually have communication between the infiltrating cells with the cancer cells with the infiltration cells, and the infiltration lymphocytes talking amongst themselves. But one class of cells which I think is interesting and is starting to show its importance in lymphomas are these immature myeloid cells, or these MDSCs. They're very important in solid tumors, and now we're starting to look at their role and their involvement in lymphoid malignancies, particularly from an immune suppression standpoint. But the one thing I'd like to point out is when looking at the microenvironment, what's important is to understand your model system that you're using. Because I always say the results that you obtain from your system are only good as the limitations of your models. And when looking at myeloid suppressive cells, there's a big difference between what we're seeing in murine models and what we see in human tissue. So for example, when looking at solid tumor models of pancreatic cancer, the KPC model, what we see is we see a massive expansion of these immature myeloid cells, where it's almost like a leukemic phase. You see the massive immature in the marrow and the spleen that migrate towards the tumor into sites of metastasis. And when we look at patient samples, we don't see this massive expansion of these myeloid cells. So you kind of have to look at the results and how could we interpret them. So in the B cell microenvironment, there's a number of players. So first I'll cover CLL and not take too much of the thunder from Dr. Wiesner's talk in the next session. But a number of cells have been shown to be involved in the CLL microenvironment. So you have the nurse-like cells, monocyte-derived nurse-like cells, you have stromal cells, and various T cells. And these activate a number of receptors on the B cells. So you have the TNF family of receptors such as BRAF, CD40, then you have the chemokine receptors, which are important for homing and also for survival. Lately, a lot of people have been focusing on the integrins, which I think at first have been kind of ignored, but these have showed that they're very important in the adhesion of these cells when they reach their microenvironment. And of course, the B cell receptor, which I'll focus on right now. So the B cell receptor has been shown important, and I'll talk about some of the agents, but upon activation, you see activation of a number of important signaling nodes, focusing on PI3K delta and BTK, and also a little bit of SYK. But what the B cell receptor does is it's very important for translational control and transcriptional control, which will then lead to cell survival and proliferation. But in addition to survival and proliferation, the B cell receptor has been shown to be very important with signaling to the microenvironment by secretion of chemokines CCL3 and CCL4, which are important for the recruitment of T cells and engagement of the CD40 receptor. But in addition, it's shown to be very important, involved in activation of integrins, so you see cell adhesion. So a number of molecules have been developed that will inhibit various nodes of the B cell receptor pathway. And I'm just using just general terminology. So you've had SYK inhibitors, BTK inhibitors, and PI3K delta inhibitors. And what's interesting is they've shown preclinically and clinically similar effects. And from a preclinical standpoint, they're very similar. But what's interesting, and I think Dr. Barr is going to talk about in the next session is, and which I'm very interested in, is looking at the combination of inhibiting both of these signaling nodes and see if in fact you'll have better responses or a more complete response. So the one thing I would like to mention when starting, I worked on the PI3K delta inhibitor at Calistoga and then also at Gilead. And the thing that was interesting about, even when we were looking at SYK and also BTK, the thing that jumped out and shows the importance of the microenvironment is if you're doing a traditional screen to look at kinase inhibitors and what's going to be efficacious, these would have all fallen through the cracks. Because when you screen them against cell lines, I mean, they're pretty dismal, and it was pretty disappointing at first. I'm like, these aren't going to work that well. But it's only when you start to look at these particular inhibitors in which I would say more complex type of experiments, more cold culture experiments and more in vivo experiments, where their true benefit shines out. And I mean, I know in retrospect, hindsight's 2020. People could have said, "Oh, I would have expected this," but personally, working hands-on, I would not have expected the clinical results that have come out of these B cell receptor type inhibitors. And that's another thing I point out is they're referred to B cell receptor inhibitors, which they are, but all three of these signaling nodes are really central pathways of the survival of the B cell, and they're involved in, as I showed, signaling from various receptors. So basically just typecasting them as B cell receptors, I think sometimes is an injustice, and I do it myself. But anyway, so if you activate the B cell receptor, the importance of PI3K delta is observed, because as anyone who's worked with CLL cells know, there's this intrinsic high level of apoptosis showing the importance of the tumor microenvironment. However, when you cross-link the B cell receptor, you get this pro-survival effect, which then can be overcome in a concentration-dependent manner with treatment of a PI3K delta inhibitor. In addition, we see, although these agents, you don't see robust apoptosis, you could see a pro-survival effect when cross-linking, which can then also come when when you look at treatment with a delta inhibitor, and this is looking at an Nexin-5 staining. Similarly, as I mentioned, it's not just pro-survival or proliferative effect. We also see the inhibition of chemokine secretions such as CCL3 and CCL4, which are important in the disease. Once again, a class effect. So if you look at a SYK inhibitor, this is work that was done by Jan Berger's group. You could see, using similar experiments, cross-linking, you see this pro-survival effect, which then could be overcome by the use of different SYK inhibitors. And once again, you could see, similar to PI3K delta, when you cross-link IgM, you see this increase of CCL3 and CCL4, which can be inhibited by SYK inhibition. So in addition to this pro-survival and the secretion, you also see this integrin effect and this effect that you see on mobility of the cells. Excuse me. So this is, once again, was done in conjunction with Jan Berger's group at MD Anderson, where you actually plate stromal cells along with CLL cells, and you look at the migration across the stromal, and you could see that if you treat with a PI3K delta inhibitor or a SYK inhibitor, you can inhibit this migration underneath the stromal level. So I've always said when we started to run the trials, this was a type of program which it was really, I think, it emphasized from the bench to the bedside, because what we started to see on the bench really translated into the clinic. And so this is from the CAL-101 phase 1 trial, the first couple patients, CLL patients that were dosed. And what we showed was similar to what we showed in our preclinical experiments. When you look at pre-dose, these patients had high levels of CCL3 and CCL4, and then at the end of cycle 1, these levels dramatically decreased. And these were derived from the CLL cells. So if you look at chemokines that are being secreted from the stromal cells, You see also a decrease, and we were looking at CXCL13, and we also saw a significant decrease in CXCL12. Now this is interesting because what's not shown here is the kinetics of this experiment. While these are being directly derived from the B cells, these were fast. So after 7 days of dosing, we already were back to baseline levels of CCL3 and CCL4. The CXCL3, after 14 days of dosing, they were about, I'd say, I can't remember off the top of my head, I should probably do this, like about a 50% reduction. And then it was only on day 28 they went to background. And what's interesting is when we look at the effect of a SYK inhibitor or a PI3K delta inhibitor on stromal cells or nurse-like cells, we really see no effect. So what's happening here is this is mimicking what we're seeing, this phenomenon, which I'll talk about, and I know will be mentioned later on at the symposia, is this lymphocytosis, where the cells are becoming dislodged. So as these cells are leaving the microenvironment of the nodes in the marrow, what happens is you're losing this cell communication, cell-cell contact to the B cell with the microenvironment, which I think then is, once again, a hypothesis, is down-regulating the production of CXCL13. So focusing on this lymphocytosis, this effect of basically dislodging these cells from the microenvironment and into the periphery, there's a series of slides, and these need to be updated now to actually add in the involvement of the integrin receptors and adhesion receptors. But what happens is you have bulky nodes, which are packed with malignant B cells, and you have pretreatment. I'm saying pretreatment here because this is like a class effect. But then but of course over here I have delta. But so this is what we see pre-treatment. So then on treatment, what we see is this initial spike in increase in lymphocyte counts in the periphery. But what's happening is you're inhibiting the signaling of CXCL13 and CXCL12. You're inhibiting the secretion of CCL3, CCL4, and then the interaction of the T cells with CD40. But more importantly, you're affecting the adhesion and also the homing chemokines. So what's happening, these cells now are being dislodged from the node and going into the periphery. So you see the spike in lymphocyte counts. And then over time, what happens is this lymphocytosis starts to resolve, but it resolves slowly. So in overview, what's interesting is you see this effect with, as I mentioned, with SYK and BTK. So you have this supportive microenvironment, and by inhibiting these signaling nodes, which are important to the B cell, you exclude these cells from their microenvironment niche, which they like, and then they go into the periphery where they slowly die. And what's interesting is these cells, there's an interesting paper that just came out in Blood from the OSU group and others, where they've looked at these cells. And what's interesting is these cells kind of are just very quiescent, and they just sit in the periphery and they die over time. But what's interesting is to undergo apoptosis, you need an active signal. And I think that these signaling molecules, delta, SYK, and BTK, are such central signaling nodes within these cells that you shut down many pathways. So these cells are left quiescent. So shifting gears for the last couple slides, what I'd like to get is more into lymphomas, and not only the role of the tumor microenvironment, but the immune aspect of the tumor microenvironment. So the immunomodulation standpoint, and I've been very interested with this with PI3K delta because of its function on T cells. But in lymphomas, the role of Tregs in the disease has been very interesting, and this kind of parallels what we see with solid tumors. So what you have is you'll have your cancer cells, which will then, along with the dendritic cells, recruit Tregs by secretion of CCL22 and CCL12. So you'll get recruiting of Tregs, but in addition, the microenvironment now that's supported, basically you'll get conversion of CD4 cells to CD4, CD25, FOXP3 positive Tregs. So you build up this Treg reservoir, which will then give it an immune suppressive environment. So somehow if you can kind of decrease the Tregs, kind of take the brakes off this and increase the body's immune system towards the cancer may be interesting. So in follicular lymphoma, we've seen this effect somewhat indirectly by looking at exogenous cultures looking at Tregs, and then also the secretion of CCL17 and CCL22 from the tumor microenvironment. But what we see is, the enrollment of T follicular helper cells, and what happens is these will engage the malignant lymphoma cells by either CD40 or the secretion of IL-4. And when these cells are stimulated with IL-4 or CD40, you see a spike in increase of the secretion of CCL3 and CCL17 and CCL22, which will then bring in these T cells, these Tregs, which will provide this immune suppression microenvironment. In addition, looking at PD-1, now I know PD-1 ligand is not expressed at high levels in follicular cells, but in other lymphomas, they're now looking at this, and I know there's been trials that have been initiated looking at PD-L1 and PD-1 antibodies. So what did we see in the clinic? So what we saw in indirect evidence of the follicular patients on the phase 1 CAL-101 trial, what we noticed was similar to what we saw with CLL, with CCL3 and CCL4. We saw these decreases, these very fast decreases in CCL17 and CCL22. And then when we would look at, and this was basically short-term cultures of human follicular lymphomas, we took a biopsy and we would grow these in the presence of 101. What you could see is, which correlates nicely with the decrease in CCL17 and CCL22, you see a nice decrease in the number of Tregs, which are infiltrating into the site of the tumor. So in closing, I think the important thing is I think there's a lot of potential for other therapeutic intervention by targeting the tumor microenvironment. As I mentioned, just from looking at CLL, looking at the results we saw that have been out there with BTK and PI3K delta and also SYK, that you have multiple nodes of interaction that can be inhibited. So you won't just block one part, you can block multiple parts and get a greater effect. And what's interesting is what's going to happen with combination of these agents, because you can overcome resistance, but you may see a greater effect when combining different agents or biologics with these small molecule inhibitors. So with that, I'd be happy to answer any questions. Thank you.